we have been quite a bit meet of the expert research part of with Dr. Tam. I don't know if you have more relevant question from the audience for Dr. Wells or Dr. Becerra. If we are finished with that, we may just give some time for clinical. We have some unanswered questions that we want to address with Dr. Davenport, Carpen, Becerra. Just let's check the Q&A box and see if we could have some extra question for the research part.
I have a question for Dr. Wells. Is she, Dr. Wells?
Yes, I'm here.
I really enjoyed your presentations in your data, and actually anybody, because we need your input. We have done single cell sequencing of our biliary organoids, and in whichever experimental setting we use, we find that when they come from the patients, that they have they have subgroups of cells and largely dependent on their oxidative balance, if you will. And it's all coming down to, looks like there is an oxidative stress in a group of cells. Another group is more hypoxic in origin. So have you assessed whether glycocalyx production or even the presence of HA changes when you culture the cells with different CO2 exposure?
We have not looked at that formally, no. But that is a very interesting idea. That's something we could do. We certainly have the capability of doing that. And that would be a very interesting idea. Yeah, we haven't done it though.
So Dr. Becerra's question reminds me that I wanted also to ask to Dr. Wells, because the model of the sheep, the fetal sheep model is very interesting. And my question is, in this model, it seems that these fetus from sheep are hypoxic. I understand.
So
yeah.
So there are two categories of sheep in the biobag. One category is normoxic, is in a normoxic environment, and one category is in a hypoxic environment. We actually see evidence of injury in both groups compared to the control that's incubated in the womb. Now, whether the group but certainly the group in the hypoxic biobags have much worse injury. So why the group in the normoxic biobags have injury, we don't know. I mean, whether it's hypoperfusion, whether it's whether they're actually somewhat hypoxic, it's hard to say. I mean, it's a very complex model, and you know, I think there are a lot of things happening in those animals. I think we use those animals more to look at the response to injury than I think it would be very difficult to figure out what the actual source of injury in those animals is. So,
and to that, so two short questions. One is there any other organs affected similarly to the biliary tree in this model? I believe so, but I'm not privy to all of the data about other organs in that model. I think just put it that way. Okay. We only were provided access to the bile ducts, but I do believe that there was damage in other organs. So my question will be, yeah, and maybe for the clinicians too, because I'm not dealing with these patients. So I would like to know if the mothers of the kids with biliary atresia seem to have placental insufficiency or something like that, you know, like the 3 phenotype or something, you know,
there is any evidence in humans of this sort of placental insufficiency in the mothers of biliary atresia kids. I don't know if that's something that we know or not. There's Carlos, Jorge, or Sol.
And I could begin to answer. It's certainly not been fully studied, but it is not anything that's been discovered in any way, shape, or form. I think the inheritance of biliary atresia is really a very important discussion point, because there is no inheritance of biliary atresia. We love to think of Mendelian traits, but there really aren't. Others may feel different, but when I counsel families, I say that the risk of your child that just had biliary atresia is roughly in North America 1 in 10,000, let's say. So is the same risk for your second child, were you to have a future child. So I think that it's a very hard sell. We focus on BASMs, as many of you know, and we look at a lot of the genetics there. There's no heritability that anyone can see, even in the BASM families. So there are genetic contributions for sure, but genetic sole causations are really a harder sell. So looking at prenatally, the only thing that has been studied, and I believe it, are prenatal ultrasounds. That there are people who have followed prenatal ultrasounds to follow gallbladder length at certain gestational ages, and that one can pick up BA in some of these patients with that particular metric. As far as other prenatal findings that one looks for, I am unaware of them, but maybe Georgie or Carlos or others are aware.
One little contribution about your BASMs, actually. When we originally described it, we did find that those were very definitely affected by certain prenatal events, and maternal diabetes was one obvious thing. It wasn't a genetic thing per se. It was an example of an abnormal first trimester environment, and there were other things, hypothyroidism in the mothers as well. And we've chased that for a number of years, and nothing else other than the syndromic ones have really stood out. We've got a suspicion that IVF babies seem to be more predisposed to the development of certain abnormalities, typically biliary atresia, but again, it's such a difficult thing to work out because it's getting more and more frequent. And of course, you know, there's the potential problem of the older parents anyway, even if it was IVF. So it's a very, very difficult area.
Joseph, Maria, this is a really interesting question. We know a couple of facts. One is that there are data published by Jorge dos Santos that show that there is increase in HIF, hypoxic induction factor, in livers, and a subgroup of livers of patients with biliary atresia. They actually have a quite interesting arterial hypertrophy, if you will. Also, some of our unpublished data in the lab show that if you change the matrigel glob that we grow this organoid in, so that it changes the oxygenation of the organoids, they may actually grow quite remarkably on a relatively hypoxic condition. So I think that the oxygenation event that may happen, whether it resides in placenta or otherwise, remains something very interesting, very difficult to explore in a project, because these patients come and usually the placenta is gone. Because
I think placenta should I think placenta should be studied, and I think it's the easiest tissue to get for a biobank, because you know it's going to be discarded, so or use it for progenitor cells in some cases, but placenta itself, it's not usually kept. So I think that is a good. So that should be something really feasible. Sorry,
there is one study from Stellenbosch in South Africa which did look at placentas, and they did seem to show, compared to controls, abnormalities in the placenta, although they're fairly non-specific abnormalities, but they seemed convinced and was pushing this sort of prenatal ischemic placental event as a possible cause.
A question to Rebecca. Knowing that the extrahepatic bile ducts suffer a lot more than intrahepatic bile ducts in biliary atresia, have you checked permeability in intrahepatic biliary cells to link if the permeability is the key point of the disease progression in this tissue?
So I think it is one component. Measuring, so the cells themselves, if we culture them in our bile duct on a chip, as long as they grow to the same density as adult cholangiocytes, they have the same permeability. Permeability seems to be a function of density. And in a neonatal extrahepatic bile duct, cholangiocytes are much less dense than in the adult. So one thing we need to do, and I'm sure someone in my lab will send me a note on the chat if I get this wrong, but I don't think we've actually looked. I've gotten a number of notes, which is good. I don't think we've looked at the density of cholangiocytes in the intrahepatic ducts. I will say, though, I think it's a slightly different situation if you have high permeability in the intrahepatic ducts compared to the extrahepatic duct. In the extrahepatic duct, if you have leakage of bile beyond the epithelial layer, it's flowing into the submucosal compartment that has primarily proteoglycans and has minimal collagen and is likely to be free flowing. We've tried to model that in sort of in vitro, and that does seem to be the case. Whereas in the liver, if you have leakage in the intrahepatic ducts in the neonate, it's a different environment that is then getting exposed to bile. So I'm not sure. I'm not sure it'd be as damaging in that setting. But it's a good point. We should actually count cell density in the intrahepatic ducts.
Okay, thank you.
On that, one thing, Becky, I think that's really interesting. It's not directly applicable, but I think it provides a proof of concept. There are some mouse models that Dr. Paul Mongo has worked with, where he has tight junction mutations, and he studies these mice with intravital microscopy, where he can track how bile can actually go between the cells and out into the periphery in a live liver. In other words, under the microscope. And what you actually can see, I think it's a beautiful proof of concept that really fits in well with what Becky is really leading the charge on, is that the cholangiocytes are not really performing their barrier function very well, or are also more susceptible themselves to taking up bile acids, because the concentrations are tremendously high. Once you get beyond the first few weeks of life, they're very high within the canalicular space. And if they can get through into the bile ducts, they're very high in the bile ducts. And if these are immature, less than fully functional cholangiocytes, you have a really nice hypothesis there. But I just wanted to bring up the work from Paul Monga, which shows that in some mouse models, one may actually be able to test these hypotheses with the right equipment.
There is actually also a mouse model of E-cadherin knockdown in the intra and extrahepatic ducts. And I think that there is a suggestion of some significant damage, but I have to go back and look at those papers in light of that idea. But it's something that we've intended to test using those mice.
Okay, thank you. I think that, I don't know, I think we are done in this research part of meeting the experts. I'm seeing that
there is one question here, Carlos.
Yeah.
There is one question. I can. Is actually no, the one question for Dr. Davenport actually. Yeah.
Dr. Davenport is.
I'm in the wrong section
clinical.
here, I think.
Sorry
You
about
are
that.
infiltrating.
Okay.
You are infiltrating the session.
Okay, I'm switching there. So I think, yeah, I think the interesting thing is the conversation between both, you know, the specialties. So is in relation to the use of steroids post Kasai. Have you seen any difference between the group of CMV positive and those CMV negative?
In terms of steroids?
Instead of response to steroids.
Well, I mean, if they were CMV positive, we wouldn't have been giving them steroids. I'm not saying that didn't happen, but it was an actual exclusion for all our trials that if they were CMV positive, they didn't get steroids. Although actually, when you think about it, possibly that is a valid way of treating them. But they actively didn't get it.
So, it's important thing that you're saying. So there's a important number of your patients that may not receiving these steroids. So, even though you do, okay. I want to take advantage that we have in the panel also another pediatric surgeon, besides being a terrific scientist. My question, you said something like you would not offer a portosystemic shunt in a well-preserved liver function biliary patient. Differently than we may do, or we adults does in a cirrhotic with a very good liver function. They do like selective shunts, and they do very well. Okay, so I want you, Dr. Davenport, to get deeper in that question, and Dr. Paul, if you want to do something or just to say something as well.
It was Saul that actually said that one. You can't attribute that one to me, but nonetheless, I clearly have a comment on it. We wouldn't advocate portosystemic shunts. So I think we agree between ourselves that if they're severe enough, and if you can't control the varices with endoscopic treatment, and they need something else doing, they really should be forwarded to transplant. Very, very few. The only people that really have a great experience of that is the French, who were advocates in biliary atresia children with good liver function. Apparently, they would be doing some kind of shunt operation. But I guess that's largely historical. I guess even they have sort of given that up.
Dr. Tom?
Yeah, I think the shunt aspect would be something that we hope we can avoid if we can do better with our management in early infancy, because this is late stage complication, and I'm not sure it is different from other patients who have this need of a shunt when you have cell damage, fibrosis of the liver, irrespective of the etiology. The treatment required would be similar, like what Mark just said. When you're well into near end stage liver failure, then the only logical solution would be a liver transplantation. But we do want to avoid that, and we believe that it is possible to slow the process down. We completed a long-term study recently on our patients, and we have something like 60% of our patients surviving with native liver. And in those patients, we deal with consequences of the portal hypertension by endoscopic surveillance, variceal injection at an early stage. Then for the hypersplenism, we are leaning towards arterial embolization, partial reduction of the hypersplenism to control the outcome of the portal hypertension. But we are not doing nothing about the cause of the portal hypertension. And I think that's where the antifibrotic treatment will come in. But I think that the perhaps biliary atresia at least takes 2 stages. The first stage, when the disease is formed, has a very heavy inflammatory immune component plus developmental aspect. And then the second stage is the more fibrotic pathway. And maybe we will be smarter in future when we know how to mitigate the process in a temporal defined sequence, when to give what. So just like what Mark said, the gut response to treating a patient who is known to have CMV infection is not to give steroid, because steroid is an immunosuppressant. But if the CMV is not an infection, but simply a trigger of autoimmune process, then why not give steroid or other more sophisticated targeted immunosuppressant? I believe there will be a very strong role of immunosuppressant therapy in the treatment of biliary atresia, but we just have to know who and which and when.
Perfect. Dr. Becerra.
I really enjoyed this conversation, and I think that I'm going to pick on something that Mark mentioned earlier, that he said that his colleague in Japan does the laparoscopic Kasai, and then he doesn't give up. He reports high success rate, but he does not give up. Then listening to Paul, I think that your initial question about what to do with a patient that has portal hypertension, that is otherwise doing very well with liver function, will become a real issue 5 or so years from now, because if we learn more about what is being done in Hong Kong, in Japan, they have, remember Dr. Saul presented that graph that we always have a drop in success in the first 2 years of life. If we can do something to push that to the right, we are already improving the life of these patients, probably. So I think that Paul is right, that we're going to have different things to offer. We have a paper, we submitted a paper about a change in our protocol at Cincinnati. It shows that we have tailored the use of different treatments to the patient immediate response to Kasai. I think that, to be fair, it's better that we wait for the reviewers to go through, and we'll see if it gets published before we talk. But I think that we should learn more about those centers that have somehow not given up, and they have reported much higher success rate.
Very good.
Sorry,
yeah.
Carlos, just taking advantage of this conversation about the immunity and and the use of steroids in these patients. So I think it was very interesting for me the data showed by Dr. Zhang, who I hope is there, although it's very late, but because all the prevalence of
She's there.
She's there. Yeah. Okay. probably the prevalence of anti-Rho SSA antibodies. That I don't know if that's reported in your paper. I don't remember, or it's reported in literature, but seems to be an important mechanism, you know, by these deregulated B cells. Maybe I'm saying something wrong. You can correct me. But it will be very interesting not to stratify also the patients whether they have or not autoantibodies, because I think that also anti-neutrophil cytoplasm antibodies or anti-nuclear antibodies, they're very frequent in these kids. No, maybe that's a sign of the these B cells that have not passed through the central tolerance mechanism, and they are there producing these autoantibodies. That could be a sign of the steroids are a good choice for them. No? That makes sense.
The steroids, I don't know.
So maybe not only steroids, but any, you know, anti-CD20, maybe then, you know, anti-BAF or whatever.
So the main reason for steroids, it appears to me the liver is more like a hypo-inflammatory, at least in that cohort we were studying. But when you look at the intestine, then it's a little bit more hyper-inflammatory. So the gut-liver circulation in the patients actually quite different. If you just suppress inflammation further, then autoreactivity could be increased, but then it might be required for the intestine. So when we look at the data from intestine liver, the disease seem to be the two organs are contrasting in their inflammatory profiles. So whether would steroids be the best choice, or there might be some other more targeted therapies or combinational therapies. I don't have much experience, but I think there's some epidemiological studies saying the application of that wouldn't increase long-term native liver survival or something like that. I think you guys might have more experience.
Okay, I'm wondering if this is the question goes to Dr. Becerra, and of course Dr. Carpen.
Sorry, Carlos, I think Dr. Carpen has his hand up.